Good afternoon, everybody, and welcome to our second ACCP AST Resident Research Webinar of 2026, supported by the ACCP Transplant PRN as well as the AST Transplant COP. My name is Crystal Vo, and I am currently a PGY1 resident at Mayo Clinic in Arizona, and it's my pleasure to moderate today's session alongside with Samantha Shirk, also a PGY1 resident at Mayo Clinic in Arizona. We are honored to hear from some of our residents' research today. But before we get started, friendly reminder, this webinar is available for CE credit. An email will be sent out to our attendees at the end of the webinar to obtain CE from Rush University. For our audience members, please ensure that your microphone is muted for the duration of today's presentation. The mute button is located in the lower left-hand corner of your screen. If at any point during the presentation you do have a question for our speaker, please submit your question by using the chat functionality at the bottom of your screen, and we will take questions at the completion of each presentation. Today's webinar will be recorded and posted on the ACCP Transplant PRN YouTube channel. And if you happen to experience any technical difficulties during this webinar that is not fixed by logging out and refreshing your internet connection, please let either Samantha and I know through the chat functionality. Now, without further ado, I will turn over to Samantha to begin our webinar.
Yes, thank you, Crystal. So for today's presentation, we will primarily be focusing on the advancing transplant care, novel therapies, tools, and practice models. The objectives for today's presentations will be evaluating emerging research findings from pharmacy resident projects in solid organ transplantation and their implementations for contemporary clinical practice, be able to describe the emerging therapies, clinical tests, and pharmacy practice models in transplant care and their potential to improve patient and system level outcomes. And lastly, identify opportunities to optimize transplant center practices based on presented data, including areas for future research. For this webinar, all individuals in control of the content have no relevant financial relationships to disclose, nor does anybody presenting this today. But presentations can discuss off-label medication use as well. There is a joint AST and ACCP research committee that created this research toolkit that's available for members in the AST COP Hub and on the ACCP Transplant PRN websites. Check it out for helpful tips on regulatory information, data management, and survey-based research. But without further ado, I will now hand it over to Jack Adams, which is a PGY2 solid organ transplant resident at Children's Healthcare of Atlanta.
Thanks for that introduction, Samantha. So today I'll be discussing my research, which was the evaluation of sodium glucose cotransport 2 inhibitors, which I'll be referring to as SGLT2 inhibitors throughout the presentation in pediatric heart transplant recipients. Like Samantha said, no disclosures. It is not letting me progress the slides.
How about now?
No. There we go. Here is a list of abbreviations I used throughout the presentation. It is stuck again.
I can share it from my side as well.
Yeah, and I'll just let you know when to advance.
Yeah.
All right. Sorry about that. So just a little bit about the practice site where this research was conducted. Children's Healthcare of Atlanta is Georgia's only nationally ranked pediatric cardiology and heart program. And we performed about 927 surgeries in 2024, with 129 of those being solid organ transplants for heart. You can go to the next slide. I set a few objectives for today, so just provide an overview of pediatric heart failure and how that's relevant to pediatric heart transplant recipients, discuss the potential roles of SGLT2 inhibitors in pediatric patients and their anticipated clinical impact, and identify any current knowledge gaps and future research directions for SGLT2 inhibitors. Next slide. So just a brief overview of pediatric heart failure. It's a complex clinical syndrome resulting in impaired ventricular function. And so this is kind of classified by your volume or pressure overload and your ejection fraction. Some common etiologies include congenital heart disease, cardiomyopathies, rhythm disorders, or if it's just acquired. And then some symptoms, it kind of depends on your age. So for infants, this is typically demonstrated through poor feeding, tachypnea, diaphoresis, or failure to thrive. And for children and adolescents, you can start seeing more of those classical adult symptoms. Next slide, please. In terms of pediatric heart failure pathophysiology, there's a few compensatory mechanisms. So our first here is the sympathetic activity. Increase of sympathetic activity due to decreased cardiac output. So we get overactivation of beta receptors in the heart, our alpha receptors and beta receptors on the kidney, trying to increase that cardiac output. And if you could advance it for me, please. Then we also have an overactivation of our RAS system due to decreased renal blood flow, increasing angiotensin, aldosterone, trying to increase our blood volume and fluid retention to drive up cardiac output and increase renal blood flow as well. Next slide, please. And so there's a few different direct medical therapies that we can target, with them being beta blockers, mineralocorticoid receptor antagonists, RAS inhibition, or like today we're talking about SGLT2 inhibitors. Next slide, please. And so the way that SGLT2 inhibitors work in heart failure, there's two mechanisms, with it being osmotic diuresis. So it blocks glucose reabsorption in the proximal tubule of the kidney. And so that creates this osmotic diuresis. And then it also increases cardioenergetics. It's thought to actually increase the absorption of ketones, and hearts can utilize that as a new energy resource. Next slide, please. And so where do they kind of fit in within our recommendations? So the ISHLT guidelines for pediatric heart failure recommend them for both HFrEF and HFpEF. However, their safety and efficacy hasn't really been systematically studied in children. And so we borrow a lot from our adult colleagues, where in the 2022 guidelines, it's been shown for adults to decrease hospitalizations in HFrEF and HFpEF, and also improve cardiovascular mortality in HFrEF. Next slide, please. And so where the literature really stems from in pediatrics, there was this study done in 2023 that looked at kind of characterizing dapagliflozin use in children, and it showed a decreased efficacy in BNP and improvement in their functional class. And there was shown to be no hypovolemia, again, when you think back to that osmotic diuresis or hypoglycemia. 4 patients did experience AKI, and this could have been contributed to that diuretic effect, and 6 patients experienced UTI. When you think about excreting glucose through the urinary tract, that is just breeding ground for bacteria and fungal infections. In terms of limitations, the majority of these patients were on guideline therapy, and so there was no comparator group. And the biggest limitation is this only included 3 solid organ heart transplant recipients. Next slide, please. And there was a similar multi-center study done through ACTION, and they found very similar side effects and rates of AKI. However, the biggest limitation was, again, no heart transplant recipients. Next slide, please. And so this brings us to my research today due to the lack of literature and understanding of SGLT2 inhibitors. So we wanted to evaluate their efficacy and safety in children with heart transplant. So our primary endpoint was looking at change in BNP before and after SGLT2 initiation, and our secondary endpoints were looking at mortality, retransplantation, and if they required mechanical circulatory support, and change in diuretic requirements. Next slide, please. And then in terms of our safety outcomes, we were looking at incidence of AKI, which is defined on the screen, hypoglycemia, incidence of UTI, and if there was discontinuation of SGLT2 inhibitors for any reason. Next slide, please. In terms of our methods, this was a single center observational study of pediatric patients with heart failure who received a heart transplant from 2020 to 2025. Patients were included, obviously, if they had a heart transplant and they were less than 21 years old. Patients were excluded if they were on any other SGLT2 inhibitor besides dapagliflozin or empagliflozin, as those are the SGLT2 inhibitors recommended by the guidelines. And if it was started for a non-cardiac indication such as CKD or diabetes. So in total, we had 36 patients. Next slide, please. Just for continuity's sake, I just included a description of our statistics. Next slide, please. So looking at our baseline demographics, our children were about 15 years old, with a majority of them being female. And then in terms of cardiac etiology, causing heart transplant, congenital heart disease, and cardiomyopathies were about split. Next slide. And then I just also wanted to include their guideline-directed therapy throughout the 6-month follow-up. Next slide, please. And so in terms of our primary objective, the change in BNP, this blue line is showing that BNP throughout 6 months. And so as you can see, there was a decrease in BNP as expected when the SGLT2 inhibitor was initiated. Next slide, please. In terms of our secondary objectives for outcomes and safety, in terms of death, about 6 of our patients, so about 16.7%, sadly passed away. And there were 2 patients that required a retransplantation. And there was only 1 patient that had to get cannulated onto ECMO after getting initiated on an SGLT2 inhibitor. In terms of our safety outcomes, we did see more AKI compared to the ACTION study and that study from 2023. This was a little bit to be expected because these patients are also on additional nephrotoxic medications, primarily thinking about our calcineurin inhibitors. We did not really see any incidence of hypoglycemia, and we saw about 8.3% of our patients experience UTI. In terms of discontinuation after SGLT2 inhibitor, there was 1 patient. This patient in particular had recurrent UTIs, and her last UTI resulted in urosepsis. So dapagliflozin was discontinued in this patient. Next slide, please. In terms of loop diuretic use, there was a decrease as expected from that 6-month follow-up period, again, contributing to that osmotic diuretic effect. Next slide, please. So in conclusion, SGLT2 inhibitor initiation was associated with UTI and AKI. However, only 1 patient was discontinued off this agent, so they're pretty well tolerated. Next slide, please. In terms of limitations, it was a single center retrospective chart review. We had no comparator group, and we did not assess patients' adherence in the outpatient setting. Next slide, please. In terms of next steps, there's a few endpoints that we're going to go back and collect, such as time from transplant prior to the SGLT2 initiation, reviewing immunosuppression regimens of each patient, and then review the incidence of rejection and CAV for each patient 6 months prior to SGLT2 inhibitor initiation, and then 6 months after SGLT2 initiation. After these are collective, we're going to write up a case series, primarily putting the emphasis on the safety outcomes of SGLT2 inhibitors in heart transplant patients. Next slide, please. I would just like to thank my preceptors who helped me with this project. Next slide, please. Here's a list of my references. Next slide, please. And I welcome any questions about my research. Thanks for having me today.
Thank you for your presentation. We do have a question in the audience. Did you identify patient characteristics that appeared associated with improved BNP response?
Yeah, we did. For the sake of this presentation, I couldn't include it. So we looked at echoes at baseline 1, 3, and 6 months, as well as looking at changes in functional class as well.
Thank you.
Does anybody else have any final questions for Jack today? Okay, sounds good. Well, we will move on. Thank you, Jack. Next, we will be hearing from Myrna Ishaya, which is a PGY2 pharmacotherapy resident at Henry Ford Hospital in Detroit, Michigan.
Thank you, Samantha, for that introduction. So today I'll be discussing our retrospective evaluation comparing thymocyte globulin versus steroid-only induction in the younger liver transplant population. All right, let's see if this works here. There we go. Okay. First, I'll start to review why induction therapy in liver transplant remains controversial to this day compared to other solid organ transplants. Now, the liver is unique compared to other transplanted organs because it is considered an immunologically privileged organ. So unlike the heart or the kidneys, the liver naturally possesses lower rates of rejection due to several cholinergic mechanisms. One proposed mechanism is that the liver acts almost like a graveyard for our activated T cells. This helps eliminate the immune response that would otherwise attack the graft. There's several factors that contribute to this phenomenon that we hear of. The first one is that it poses a very unique environment, including a high density of immune cells such as dendritic cells and regulatory T cells. There's also lots of presence of cholinergic factors such as interleukin 10, which can help balance between activation and immune tolerance. And finally, because of its close proximity to the gut, there is the gut-liver axis, which is where the liver is exposed to gut-derived antigens, which can help the immune system learn to tolerate a lot of these non-harmful foreign antigens. So essentially, the liver can crosstalk with other organs and regulate its own immune response, effectively inducing systemic tolerance. However, despite this naturally protective environment, younger transplant recipients may still behave differently immunologically. So younger patients generally have a more robust thymic immune system and thymic function, as well as a strong adaptive immune system. This potentially places them at an increased risk for rejection. But at the same time, there is a risk of over-immunosuppression in these patients. Over-immunosuppression can lead to multiple different factors, such as infections like opportunistic infections, including CMV, or PJP, or EBV, or fungal infections. You're also at risk of developing malignancies, as well as having other metabolic complications like diabetes and nephrotoxicity. So ultimately, the challenge becomes balancing adequate rejection prevention while avoiding over-immunosuppression. So one strategy that is used to intensify early immunosuppression is thymocyte globulin, or rabbit antithymocyte globulin, which I will review next. So as we know, RATG is a T-cell depleting agent that's commonly used in kidney, heart, and lung transplantation. Its mechanism oftentimes includes profound depletion of T-cell lymphocytes, which can persist for several months, up to 6 months after administration. Now, while this may reduce rejection risk immediately, it also introduces several important safety concerns. Patients are at increased risk of infection, especially since the T cells can take up to 6 months after to help regenerate. Malignancies, because it deeply depletes our T cells. High or prolonged exposure to thymocyte globulin suppresses our body's natural tumor surveillance, which can put us at an increased risk of post-transplant malignancies. And finally, immune-mediated reactions. So thymo can trigger a severe life-threatening reaction called CRS, or cytokine release syndrome. And this systemic inflammatory response can occur when the drug provides massive acute activation of our immune system. Now, all of these risk factors kind of put us at a very difficult pace. So to understand what evidence currently exists in our time, I'll briefly explain two key studies evaluating induction therapy in our liver transplant population. So the first study was done back in 2009. They looked at 90 adult liver transplant patients comparing to thymo induction versus no induction, or steroids only. And their median age was 50 years old in both cohorts. They evaluated and saw that there was no significant difference in biopsy-proven acute rejection between the two groups. However, patients in the thymo group also had increased incidence of infections, primarily CMV infection. In contrast, a study done in 2019 by Bitterman and colleagues had a much larger transplant population. They had 70,000 patients. Their median age group was also similar at about 56 years old. And they saw that induction therapy, particularly T-cell depleting agents, were associated with lower mortality, increased graft survival, and lower graft failure rates in comparison to no induction. They also saw that there was no difference in infection risk. So, taking these two prominent studies together, they highlight that the evidence remains controversial and conflicting, particularly regarding the balance between efficacy and safety in this patient population. Now, this prompted a lot of our transplant team to look at our policies and implement a new change, which I will discuss in a moment. So because of all this conflicting data, this is why we decided to start this project. So the purpose of our study is to evaluate the outcomes of liver transplant recipients that are under the age of 50 years old who received either intraoperative steroids only compared to thymocyte for induction. The aims of the study were to evaluate the incidence of rejection, primarily biopsy-proven cellular rejection and antibody-mediated rejection by 1 year. We also wanted to look at the differences in infection, malignancy, and PTLD by 1 year. And third, addressing broader clinical outcomes such as mortality, retransplant, and other safety concerns. Now, to address these aims, we conducted a quasi-experiment, retrospective study, based on the institutional policy change that happened in 2022. So at Henry Ford Hospital, a policy change in 2022 introduced routine thymo induction for the young transplant populations. They decided that 50 years or younger should be induced with thymocyte. So here is kind of like what our study design looked like. So between 2018 to 2022, we included any patients under 50 years old that only received steroids induction. 2022 was when the policy change was introduced to include thymo for patients under 50. So then from 2023 to 2025, we had patients included under 50 years old who received thymo. Now, because the study compared outcomes before and after an institutional protocol change, it allowed us to evaluate real-world practice patterns. It is important to note, however, that the steroid-only cohort would have been eligible for thymo induction at the discretion of a physician or the transplant team had the protocol included the use of thymo. But because it was not protocolized at the time, they just received standard steroid-only induction. So in essence, the two cohorts, steroid-only versus thymo, are very, very similar in nature, which is why we wanted to compare them to see if the addition of thymo proved benefit. Like I said, so we included liver transplant patients who received thymo versus steroids only. They had to be 50 years of age or younger and received a liver transplant with established care at Henry Ford Hospital. We didn't include anyone who had a multi-organ transplant, previously transplanted, or needed to be retransplanted within the study period. The primary outcome was incidence of rejection within 1 year of transplant. We had a few other secondary outcomes such as time to rejection, incidence of DSA, description of our treatment, and others, such as infectious. Some safety outcomes we looked at included renal function and rate of mTOR conversion, incidence of PTLD and malignancy, and rate of all-cause mortality. Now, moving on to our results, I just wanted to highlight some of our big baseline characteristics. So both groups were relatively balanced. I do want to take your attention to some of the unbalanced results. So patients in the thymo group had significantly increased number of normothermic perfusion. which may correlate to the advancing technology as the years went on. The thymo group also had increased incidence of duct-to-duct and size mismatch, which may not necessarily correlate with the need for using thymo, but maybe taking on higher risk patients as technology advanced became more common. But despite these differences, they were very similar. Moving on to our efficacy outcomes, thymo was associated with a significantly lower incidence of treatment for transaminitis. So there's a 40% versus 72% in our steroid group. It is important to note that all incidences in which treatment for rejection was employed was included in this first group. This means any sort of LFT elevations or lab abnormalities that prompted our transplant team to begin initiation for treatment was included. However, time to first rejection episode, biopsy-proven ACR and AMR and DSA development was not different between both cohorts. This is another view to kind of look at how these patients were treated. So once these patients were noted to be treated, they were reviewed in terms of treatment strategies. So steroid recycle and steroid pulse and thymo was our 3 treatment algorithm. And as you can see, there was a numerically higher number of steroid only that needed this 3 drug regimen. Our most common drug regimen was steroid recycle and steroid pulse. And you can see that more patients in the thymo group needed to do both steroid recycle and steroid pulse. Similarly, steroid recycle only was more common in our steroid only group, and then steroid only pulse was similar between the 2 cohorts. Finally, I just wanted to introduce just how immunosuppression was managed throughout this 1-year period. So at 1 month, nearly all patients in both groups had maintained 3 immunosuppression regimens. By month 3 and month 6, they were slowly weaned down to 1 or 2 drug regimens. Overall, maintenance immunosuppression patterns were fairly similar between the 2 groups, and this kind of outlines us that the induction therapy was primarily the driving force for the changes. This is why I want to highlight month 3. All right. And moving on to infectious outcomes with thymo. So infectious outcomes were generally similar between the 2 groups. Although the thymo cohort had numerically higher rates of CMV and fungal infections, these differences were not statistically significant. Rates of bloodstream infections, C. diff, and intra-abdominal infections were also very comparable between the 2 groups. Importantly, these findings suggest that this additional immunosuppression from the thymo did not translate to a major increase in clinically significant infections. We also wanted to evaluate some renal outcomes. So as you can see here, rates of mTOR conversions were numerically higher in our thymo group, 22% versus 14%. However, this was not a significant difference or statistically significant between the 2 groups. It is interesting to note that the time to mTOR conversion, however, was longer in our thymo group. This may correlate with the immediate CNI sparing approach once these patients receive thymo in the post-op, giving them a little bit more time to get therapeutic on the tacro. But overall, renal-related outcomes appeared fairly similar between the 2 groups. Finally, we wanted to assess some broader efficacy or safety outcomes. And as you can see here, rates of malignancy, all-cause mortality, PTLD, and retransplant were very, very low and very similar between the 2 cohorts. So these findings suggest that at least within the 1-year follow-up of thymo or steroid only, both of them did not appear to have a significant difference in their safety outcomes. Finally, I wanted to kind of wrap up and summarize some of our big key findings. So thymo induction in our younger liver transplant population was associated with numerically lower rates of rejection in all the different groups that we kind of discussed compared with our steroid-only induction. Importantly, these improved rejection outcomes were not accompanied by any major differences in infectious complications, mortality, morbidity, or even like renal sparing or renal adjustment. So these findings suggest that thymo may be a reasonable induction strategy in our carefully selected younger liver transplant recipients, although we definitely need larger prospective studies to further clarify some of our other long-term efficacy outcomes, as well as some other long-term safety outcomes as well. Thank you all for listening, and I am open to any questions.
Thank you for your presentation. We do have one question in the audience. Would you be able to describe your post-transplant antimicrobial prophylaxis protocols and if any changes were made for patients who received ATG?
Yeah, of course. So there was no changes in our infectious prophylaxis protocols between like 2018 up until now. We do our standard CMV prophylaxis with Valsite for 3, 6, or 12 months based on your CMV serostatus. We also do fungal prophylaxis for 1 month with fluconazole, and then we also do our PJP prophylaxis, which is standard 6 months as well. So no differences between the two groups.
Thank you.
Thank you.
Does anyone have any final questions for Myrna today? Okay, well, thank you, Myrna. And next we will be hearing from Hayden Kidd, which is a PGY2 solid organ transplant resident at UC San Diego Health.
Thank you for the introduction, Samantha. My name is Hayden. I'm a PGY2 transplant pharmacy resident at UCSD. Thanks for having me today. Just a disclosure, I have no financial interests or relationships to disclose. Here's a list of abbreviations I'll be using throughout my presentation just for your reference. So starting with the background, lung transplantation is a life-saving intervention for patients with end-stage lung disease, but long-term graft survival is often limited by allograft rejection. And to prevent rejection, many transplant centers, including us, employ a combination of drugs for maintenance immunosuppression, and tacrolimus remains a cornerstone of post-transplant immunosuppressive therapy. Tacrolimus exhibits unique pharmacokinetic properties. Its oral bioavailability is poor due to extensive first-pass metabolism via hepatic and intestinal CYP3A isoforms, including CYP3A4 and CYP3A5. And this metabolism is known to be subject to significant inter-individual variability in drug concentrations, which is influenced by CYP3A4 and 5 genetic polymorphisms. You can see here in the table a summary of the named CYP3A4 and 3A5 alleles and their respective function in enzymatic activity. So for CYP3A4, individuals with the STAR1 genotype are considered normal metabolizers, whereas carriers of the STAR22 decreased function allele typically show an intermediate metabolizer phenotype due to having reduced enzyme activity. And for CYP3A5, individuals carrying at least one STAR1 allele are generally classified as normal metabolizers, while individuals with the STAR3 genotype are considered poor metabolizers because their enzyme expression is greatly reduced or absent. Lung transplant recipients also present unique additional challenges as many require azole antifungal prophylaxis. And as you all know, azoles are potent CYP inhibitors, which can further alter tacrolimus metabolism, and it increases the complexity of PK management. The Clinical Pharmacogenetics Implementation Consortium, also known as CPIC, currently provides consensus recommendations for tacrolimus dose adjustments based on CYP3A5 phenotype only, as shown in this table below. And while numerous studies have demonstrated this impact of CYP3A5 genotype on tacrolimus trough concentrations, most have not accounted for additive drug-drug interactions such as those introduced by azole antifungals. Additionally, evidence linking both CYP3A4 and 3A5 genotypes to long-term clinical outcomes remains limited in lung transplant. So in this study, our objective was to evaluate the impact of CYP3A4 and 5 polymorphisms and concomitant azole antifungal use on tacrolimus pharmacokinetics and clinical outcomes in lung transplant recipients up to 12 months post-transplant. This was a single-center retrospective cohort study including adult patients who underwent lung transplantation between January of 2022 and September of 2025. Patients were excluded if they were undergoing redo lung transplant or multi-organ transplantation other than combined heart and lung, lacking CYP3A4 or 5 genotype data, or receiving strong CYP3A inducers or inhibitors other than the azole antifungals. The included patients were then categorized into 3 groups, CYP3A poor metabolizers, intermediate metabolizers, and extensive metabolizers. And this table below summarizes how each patient was categorized into groups based on their CYP3A4 and 3A5 genotypes or alleles. And we adopted this categorization strategy from recent studies in kidney and lung transplant populations and the proposed CYP3A combined genotype classification from the second consensus report of tacrolimus personalized therapy. I do want to note, though, the extensive metabolizer is used synonymously with those with normal enzymatic function. Continuing with the methodology, the primary endpoint of our study include 2 different outcomes. So first, the tacrolimus trough concentration overdose at 4, 7, 14, and 30 days, and at 6 months and 1 year post-transplant. We also conducted a subgroup analysis of tacrolimus trough overdose up to 6 months after stratifying the patients based on their azole antifungal use and excluding those who switched azoles during the study period. The other primary endpoint was tacrolimus time in therapeutic range calculated using the Rosendahl method, which is the gold standard in assessing time in therapeutic range for drugs with PK monitoring. Our secondary endpoints were focusing more on looking at clinical outcomes, such as alternative immunosuppressant initiation, such as Envarsus, cyclosporin, mTOR inhibitors, and belatacept. Development of neurotoxicity, defined as neurotoxicity warranting tacrolimus discontinuation or substitution with Envarsus or starting on augmenting immunosuppressive agent. Renal outcomes, rejection, including both acute cellular rejection and antibody-mediated rejection, development of de novo DSA, and survival. For statistical analysis, we use the Kroskal-Wallis test to assess the difference across all 3 genotype groups simultaneously, Mann-Whitney U test for a pairwise comparison, and linear mixed effects model to determine which factor has a greater influence on tacrolimus PK. So we had a total of 185 patients who underwent lung transplant during the study time period, and a total of 66 patients were included in this study. There was a total of 119 patients who were excluded, and most were excluded due to not having CYP3A genotype data. And this table on the right shows a summary of the baseline characteristics. The baseline characteristics were similar between each group, except there was a significant difference in their BMI. And majority of the patients received bilateral lung transplant, except a few patients who underwent single lung transplant and combined heart and lung transplant in the intermediate metabolizer group. And the most common indication for transplant was pulmonary fibrosis or interstitial lung disease. And it's not included in this table, but most patients received basiliximab for induction. This slide shows the primary endpoint, which is the tacrolimus trough to dose ratio across the 3 metabolizer groups. The CYP3A extensive metabolizer group had a significantly lower median tacrolimus trough to dose ratio at all time points through 6 months post-transplant compared with the intermediate and poor metabolizer groups, suggesting that there is an increased tacrolimus metabolism in these patients. I've also included the number of patients in each group at each study time point, and as you can see, there were substantially fewer patients available at 1 year post-transplant, which may explain why the statistical significance was no longer observed at that time point. This slide illustrates the tacrolimus trop to dose ratio after stratifying the patients by their azole antifungal use and also excluding patients who crossed over between different azoles. To just help orient you to the graph, the strong azole inhibitors are defined as those receiving voriconazole and posaconazole, while moderate azole inhibitor is isavuconazonium sulfate, also known as Cresemba. And as shown in the graph, regardless of the patient's CYP3A genotype group, the tacrolimus trop to dose ratio appears to be driven primarily by the intensity of azole inhibition, with patients on strong azole inhibitors showing higher tacrolimus trop to dose ratios. And when comparing extensive metabolizers on strong azole inhibitors and intermediate metabolizers on moderate azole inhibitors, despite the extensive metabolizers having a faster metabolism, they had a higher tacrolimus trop overdose at post-op day 30 and post-op day 180. And this really created a question of whether if it's the type of azole antifungal that has a greater impact on tacrolimus PK versus CYP3A genotype. So to understand what most affects tacrolimus levels in our patients, we use the linear mixed effects model to look at the effect of azole antifungal strength and CYP3A metabolizer group on tacrolimus trop overdose simultaneously. The model tells us how much of the variability in tacrolimus levels is explained by each factor, and azole strength accounted for about 27% of the variability compared to 14% for CYP3A phenotype, suggesting that the drug interaction from azoles has a larger impact than the patient's genetic metabolizer status. The other primary outcome of tacrolimus time in therapeutic range, we did not observe any statistically significant difference between the three groups. And for our secondary endpoints, the only statistically significant difference we observed was that the frequency of cyclosporin initiation was higher in the poor metabolizer group. And though there was no difference in the incidence of neurotoxicity, the poor metabolizer group had a numerically higher percentage of patients who developed neurotoxicity. However, I do want to highlight that there was only a total of 4 patients in the poor metabolizer group, so the results need to be interpreted very carefully. So in summary, our study demonstrates that CYP3A extensive metabolizer have consistently lowered tacrolimus trop overdose ratio up to 6 months post-transplant, reflecting enhanced tacrolimus clearance without differences in time and therapeutic range. Strong CYP3A inhibition from azole inhibitors may have larger impact on tacrolimus trop overdose ratio compared to CYP3A polymorphism alone. We observe that CYP3A polymorphism can affect pharmacodynamic outcomes, including tacrolimus-associated toxicity requiring immunosuppression modifications. And lastly, the role of proactive pharmacogenetic guided dosing in improving lung transplant outcomes warrants further study in larger cohorts. And I would like to thank Ashley Feist, Shirley Sonoda, Anna Sekezo, Victoria Russo, and Dr. Afshar for their support in this research project. These are my references. And thank you for your attention, and I'll be more than happy to take any questions.
Thank you for your presentation. A question for you. Given that azole prophylaxis has become the standard of care at many lung transplant centers, do you feel, based on your data, that the CPIC recommendations still have value in guiding initial tacrolimus dosing in this population, or are new models needed?
I think that's a great question. I think one major limitation in the CPIC guideline also is that they only consider CYP3A5 genotype data and exclude the CYP3A4 genotype data. And CYP3A4 also has a big role in tacrolimus metabolism. So I think it's a very good point that warrants further studies. And our study kind of backs off that the intensity of the ASO inhibition potentially matters more than the genotype data. I do believe that the CPIC guidelines have a utility, but I do want to advocate for a better modeling, including the 3A4 as well as ASO inhibition adding those into consideration.
Thank you.
Does anyone have final questions for Hayden today? Thank you, Hayden. We will now be hearing from MJ Alvarez, who is a PGY1 pharmacy resident at the University of Iowa Healthcare.
Thank you for the introduction, Samantha, and thank you everyone for being here today. Excited to share our findings regarding the impact of extended CMV prophylaxis in lung transplant patients. So to briefly go over some objectives for this presentation, so we're going to take a look at how extended CMV prophylaxis courses may influence CMV infection rates, as well as other post-transplant complications, and then take a look at potential risks that may be associated with these extended courses of therapy. So as we all know, CMV is a very prevalent cause of morbidity and mortality within our lung transplant patient population and has been closely related with both acute and chronic rejection. And while CMV management continues to be an ever-evolving aspect of post-transplant care, optimal strategies on the prophylaxis of CMV continues to be investigated. Currently, guidelines recommend that moderate risk lung transplant patients receive 6 to 12 months of prophylaxis, and our high risk patients receive a year's worth of prophylaxis. To give a little background on the University of Iowa Healthcare's lung transplantation program, we are a moderately sized program performing about 20 to 25 lung transplants per year. And in June of 2022, we had altered our CMV prophylaxis protocol due to what we had perceived to be an increased incidence of CMV infections. So prior to our change in protocol, our moderate risk patients were receiving preemptive therapy, and then our high risk patients were receiving a year's worth of prophylaxis. Following our change in CMV prophylaxis protocol, we maintained our moderate risk patients on 12 months of prophylaxis, and our high risk patients were actually continued on CMV prophylaxis lifelong. And the main objective of this study was to evaluate the effectiveness of our extended CMV prophylaxis courses and reducing the incidence of CMV infection at 1 year post-transplant, as well as take a look at other drug therapy outcomes that may accompany this course. So we performed a retrospective chart review for 95 lung transplant patients at the University of Iowa Healthcare from January 1st, 2017 to December 31st, 2024. We excluded any low-risk CMV serology patients, as well as any patients that may have passed away or experienced graft failure within 1 year of transplant. Our primary endpoint was the incidence of CMV infection at that 1 year mark. And then our secondary endpoints, which we will detail throughout this presentation, are listed here for your reference. And these were evaluated also within the 1 year time frame after transplant, with exception to our last outcome here, which was evaluated between 12 to 15 months after transplantation. So briefly taking a look at our patient demographics. So our pre-protocol cohort included just under 60 patients, while our post-protocol cohort included just under 40 patients. And these groups were relatively similar in terms of baseline demographics. With both groups, the primary indication for transplant being ILD. Taking a look at the CMV risk status of both groups, so we can see that prior to our protocol change, we had more high-risk patients within this population, and then following protocol change, a larger proportion of patients were considered moderate risk. And you can see those numbers broken down further underneath. So taking a look at the incidence of CMV infection within a year after transplant, we can see that with our protocol change, we saw a significant decrease in the incidence of reactivation within 1 year post-transplantation, and those numbers being mainly driven by our moderate risk groups, whereas prior to our protocol change, just under 70% of patients were reactivating within 1 year, and then following the implementation of our new protocol, only about 12% of patients reactivated within that first year. With regard to our high-risk patient population, there was no significant difference in their reactivation rates. You can see the rates of CMV disease down below. However, those numbers were insignificant as well. Looking to characterize these CMV reactivations, we can see that prior to our protocol change, all of the patients in which that reactivated in our moderate risk group reactivated at an average time of about 30 days after transplant, and our high-risk mismatch patients reactivating later on in their transplant course. When looking at those that reactivated after the protocol change, both the high-risk and moderate-risk patient groups on average reactivated 12 days after transplant, and which we believe to be due to more so impaired absorption of their CMV prophylaxis agent as opposed to a gap in therapy. So taking a look at the rates of neutropenia that may be associated with these extensive CMV prophylactic courses and the use of Valcyte, we can see that overall we didn't see a significant difference in the overall rates of neutropenia between both cohorts. However, if we take a bit of a closer look at our moderate risk patient populations, we can see that after our protocol change, we did see a significant increase in the incidence of neutropenia, which we had defined as an ANC less than 1,000. However, this is expected, as prior to our protocol change, these patients would not have received CMV prophylaxis. So taking a look at how our extended CMV prophylaxis courses may have impacted other aspects of post-transplant care, we took a look at whether or not our patients were experiencing a reduction in immunosuppression, which we defined as a decrease in their CNI goal or a discontinuation of their secondary immunosuppressant. And we can see that those numbers trend towards higher incidences within our pre-protocol group as opposed to our post-protocol group. And interestingly enough, we did find a significant difference between our two cohorts in the incidence of which their secondary immunosuppressant was discontinued. And kind of piggybacking off of that, we can see that we did keep track of rates of acute cellular rejection, which we defined as A2 or greater, and then the presence of any donor-specific antibodies within that 1 year mark, and found that those numbers also trended towards an increased incidence within our pre-protocol cohort. Taking a little bit of a closer look at why our patients may have had their secondary agent discontinued. Prior to our protocol change, we saw over a third of our patients were having their secondary agent discontinued due to CMV reactivation. And then following our protocol change, we saw that number decrease significantly to only about 1 patient having their secondary agent discontinued due to CMV reactivation. Another thing we wanted to evaluate was whether or not our patients were continuing on their prophylactic agent throughout the course of the year or having changes in therapy. And so when breaking this down into our moderate risk groups, we can see that prior to our protocol, change, these patients were not maintained on any CMV prophylaxis, and almost 3/4 of them by the end of the year were on some sort of CMV prophylaxis due to reactivation and utilizing secondary prophylaxis. In evaluating our moderate risk groups after our protocol change, we can see that the majority of patients were maintained on valganciclovir throughout the duration of their first year, with only a small amount switching to letermovir. And then evaluating our high risk groups, we can see similar numbers compared to our moderate risk post-protocol group, in which the majority of patients were maintained on valganciclovir, with only, again, a small amount switching over to letermovir within that first year after transplantation. And interestingly enough, following our protocol change, we found that over 50% of our high-risk patients were being switched over to letermovir for what we presume to be neutropenia or counts that were trending towards neutropenia. We also presume that this may be due to just the increased prevalence of letermovir in prophylaxis of CMV in our solid organ transplant patients. And lastly, we wanted to evaluate whether or not our institution was adhering to our specific protocol. And so that being patients that were moderate risk were to have their CMV prophylaxis discontinued within a year to 15 months following transplantation. And we found that 64% of our patients were actually not discontinued appropriately, with the primary reason being the worry that these patients would be non-adherent to our laboratory follow-up schedule, which included weekly CMV PCRs for 12 weeks after the discontinuation of their agent. We did trend whether or not patients following the discontinuation of their prophylactic agent were reactivating within that year following the discontinuation, and those numbers proved to be very similar in that half of them reactivated within that year time frame, and then the other half did not. So to kind of bring it all together, we can conclude that the implementation of this extended CMV prophylaxis regimen significantly reduced the number of CMV reactivation within 1 year after transplant, specifically within our moderate risk group. Similarly, we found that there were significant increases in the rates of neutropenia within this moderate risk group. However, overall, there was not a significant difference between the two cohorts. And the use of extended CMV prophylaxis regimen was correlated with less reduction in immunosuppression within that 1 year time frame, and may suggest that this can contribute to reduced rates of acute cellular rejection, as well as the development of donor-specific antibodies. Thank you once again for everyone for being here, and a special thanks to Jocelyn Faircloth that served as my primary support in making this research presentation. And I'm happy to answer any questions.
We do have one really quick question, just because we're a bit over time. But
Sure.
Can you talk about how most of your high-risk patients end up on letermovir, and when you feel letermovir should be used in lung transplant?
Yeah, so we had saw an increased rate of our patients being switched over to letermovir for what we presume being ANCs that were trending towards clinically significant neutropenia. And so at that point, we would look to switch our patients over to letermovir just due to that decreased incidence of neutropenia that's associated with the use of that drug.
Perfect. Sounds good. Thank you again for your presentation. Well, I know we're a little bit over time, so I appreciate everybody who came to our last webinar, our last resident research webinar this year. Again, CE credit instructions will be sent out after this meeting. But thank you for joining again. Have a good rest of your day, everybody.